Good evening and welcome to this evening's Adam Smith Institute webinar. Thank you all very much for registering and spending an hour of your Tuesday evening with us. My name is Daniel Pryor and I'm the head of programs at the Adam Smith Institute. For those of you who aren't familiar with us, we're a free market think tank based in London in the UK, and our goal is to try to change public policy and public opinion through our research, media, events and education programs. Onto the topic of tonight's webinar. Drug-related deaths in this country are sadly never far from the news. You may have seen that 4 young people in or around Newcastle died earlier this month, and early reports suggest that MDMA and ketamine may have been involved. If you look at the latest ONS data available, that shows that drug-related deaths in England and Wales are at their highest level since records began in 1993, with the death rate in the northeast being particularly high. Scotland's drug death rate, incidentally, was recently the highest in Europe. And in the view of us at the ASI, these tragedies and many others like them are made more likely by outdated approaches to harm reduction and regulation. So this webinar is about the things that we can do to help stop some of these drug-related deaths. Universities sometimes fail to offer their students suitable, effective advice on safer substance use, while politicians block initiatives like drug consumption rooms that are designed to tackle overdose deaths. We also have a total absence of control or regulation in the criminal market that leaves millions of Brits at greater risk of harm, and change we think is needed. So in this webinar, we're delighted to be joined by 3 experts in harm reduction and drug policy to discuss the changes that need to be made if we're to start reducing the number of drug-related deaths in the UK. And once we've heard from them, we'll be going to audience questions from your fine selves watching along at home, as well as those that have been sent in beforehand. But for now, let's kick things off with our first speaker. Unfortunately, Alicia couldn't make it tonight, but we're delighted to be joined by Ada Ozcebucu. She completed her bachelor's degree in neuroscience at UCL, after which she read for an MPA in science, engineering and public policy with a focus on science advice for policy and health systems. She's also been involved in Drugs and Me, which is a social enterprise providing evidence-based information on drug harm reduction. And she's currently co-directing Neurosight along with one of our other speakers tonight, Paul North, to help reduce drug-related harm in organizations such as universities. So Ada, over to you.
Thanks so much for having me today to talk about such an important issue. First of all, I'm relatively new to this field compared to many people in this panel. But actually, I've been a postgrad student during the lockdown, and it provided me with a good understanding of student psychology and behavior on top of the work I've been doing with Neurosight. So how can universities improve their approach to safer drug use? As a start, there are 3 important things that universities should do. First of all, they should accept that students use drugs, and they use drugs for various reasons. They might be using it for fun, they might be self-medicating with it, and they might be even depending on it for whatever reason that might be, maybe it's social anxiety. And they'll keep using drugs despite university policies. They are already making the decision to use a drug despite the broader criminal justice system. So why would university, preventive university policies would achieve preventing that? And I think it's naive to think otherwise, because students already know that drug use can be fun, and most of the time it's not as dangerous as it's portrayed to be. So they already don't trust the authorities on this issue. They are not most of the time going to take on board what they say. Also because most students start taking drugs before university. University is an international place, and some international students come from countries where it's okay to use some of these substances. on top of that, nowadays it's so easy to get all these drugs. We've seen that students are increasingly using the dark web, and oh my God, it's convenient. You know, you just order it online and it's delivered to your door the next day through Royal Mail's first class. So as the second point, universities need to realize that most drug use is not problematic. Drug use isn't as black and white as some people like to see it. It's not you either don't take any drugs and be completely safe, or take drugs and become addicted to them. Drug use is more like a spectrum, and you have a lot of drug users in between. However, universities tend to address the extreme ends through prevention and treatment. And there is no support regarding the drug using population in between. That's when harm reduction becomes relevant to students. But unfortunately, it's still a controversial approach for many universities. At the end of the day, a lot of students try drugs out of curiosity and experiment with it for a while without adopting problematic habits. To them, university is an exploration period. It's a period in which they take risks and behave in an irresponsible manner because they can afford to do that. But as they get older and take on more responsibilities, their drug use decreases, at least for most of them. So as my third point, it's important for universities to see this period as a risk-taking period, which they should support their students to pass through this risk-taking period safely. And once they have that approach, then they'll start designing their policies accordingly. So yeah, once they've done these 3 steps, they'll start seeing the problem, framing the problem very differently, and therefore they'll be able to come up with the right solutions. Because currently, from what I observe, universities are trying to solve the wrong problem. They try to prevent drug-related deaths by preventing drug use. However, it's not that simple. The case of international drug policy tried that already, and we've seen that it's not working. So once we reframe the problem, we need to come up with the specific interventions as solutions. And you may ask me what these specific solutions look like. Well, specific interventions and solutions will be different for each university and even for different times. Because drug behavior of students changes and the surrounding factors are different for each university and each year even. As we can see, students' drug behavior is very different this year compared to last year. Because COVID happened, and they are under lots of stress, they are worrying about uncertainty about the future. So a lot of the drug use has shifted from having fun to escaping reality, and that's problematic. So it's essential that universities understand the behavior, attitudes, and needs of their students. Accordingly, they need to guide their students' behavior in the right direction. And they can't do that unless the university is aware of what the situation is like, what sort of factors affect students' decisions about drugs, and what sort of needs students address by using these drugs. Then, it's also not enough to just guide their behavior, but the university also needs to provide students with the resources and mechanisms to actualize these less risky behaviors. I'm aware that I'm talking at a very, very high level. So if we use COVID as an example, we actually had a good idea of young people's drug behavior before the start of this term. There have been lots of surveys, including ours, that were conducted during the lockdown. And we could observe how the pandemic was affecting young people's mental health and so on. And we knew students started buying their drugs online. We knew they were taking more depressant drugs. And we could guess that partying during Freshers' Week would be in student halls and flats because clubs and bars weren't an option. Once you know this, you can guide students' behavior in various ways, right? You can warn them about the additional risks of buying drugs on the dark web, for instance. Like if they buy cocaine on the dark web, its purity will be higher than street cocaine, most likely. And this will be especially risky if they mix it with alcohol. But currently no one tells them that. All they hear is don't do drugs or don't buy them online. But if they've already made that decision, then they need more guidance to keep them safe. Perhaps you want your students not to use drugs as a way of escaping from reality when they are feeling negative about the present and the future, and you want them to have other coping mechanisms. Well, in this case, simply telling students using drugs to escape reality is likely to lead to dependence is not going to make a difference, is it? You need to also provide them with the interventions to improve students' mental health, such as, you know, you can provide them with additional counseling services. Perhaps you are going to deliver some workshops on resilience building and things like that. So that's what I mean by, you know, it's not enough just to guide their behavior, but you need to provide them with the right resources to do that. That's why it's so important for universities to have a well-being oriented drug policy, and now more than ever it's a time for all universities to take this seriously, because there are so many external factors that will push students' drug behavior in a more risky direction. This is all I have to say. Thank you.
Well, thank you very much, Ada. Just a couple of questions from me before we move on. I guess it's more of an informational question. What does the law look like in this area if, say, a university catches a student using drugs? Do you know if they're obligated to report them, or is it something that there's a bit of a grey area about?
I'm not very knowledgeable on the legal side of these things, but I know that like they can implement different diversion schemes, because like these things are already implemented in the criminal justice system. You know, if you get caught with possession, you are not necessarily having a criminal record. You might be diverted to treatment service or education. So universities can implement similar schemes in which they, you know, they define different levels. Maybe one warning will, I don't know, make them, will send them to workshops. A second warning will, I don't know, send them to treatment. Third warning will send them to police, things like that.
And just one more from me. You mentioned that the kind of form of drug use among students has changed as a result of lockdown. What sort of impacts might taking drugs in student halls rather than, say, nightclubs have on the safety aspect? You've covered the kind of dark web thing, but I imagine, you know, if you aren't taking drugs in a nightclub, well, you might not drop too many pills in the queue so you don't get caught by sniffer dogs, but equally, you might not have trained staff on hand. So kind of a few different impacts, it seems there.
Mm-hmm. Well, there are a lot of factors in that, because you might argue that, you know, when you have to take your drugs in a club setting, then it can be riskier, because as you say, you're just like, oh yeah, I'm going to take all my drugs now because I don't want to be caught in the club. But then if you are experiencing a problem, then the people in the club will help you. If you are in a flat or a student hall, you are not going to have that safety net. And most of the time, students are really scared of being punished, even if themselves or their friends, you know, are conscious on the floor. They won't. Most of the time, they don't want to contact anyone, call the hospital, call the unit, you know, they are just scared of punishment. Why? So in that sense, yeah, it depends on the situation, basically.
Yeah, for sure. Well, thank you very much, Ada. We'll come back to you for the main Q&A. And just a reminder to people watching along at home that you can ask questions for our speakers. We've got a Q&A tab at the bottom, as well as the chat tab. Moving on to our next speaker, who is Paul North, the Head of External Affairs at VoltFast, which is an advocacy organisation that we've worked with on reports a number of times, and they seek to reduce the harm that drugs pose to individuals and society. Paul is a criminologist and an addiction specialist with 9 years experience working in the drug treatment sector, where he managed services and delivered addiction training programs and also lectured at universities. And he's going to be speaking to us on how we can improve our drug treatment and harm reduction services across the entire nation and not just in the university setting, and what other things need to change. So Paul, over to you.
Cheers, Dan. Thank you very much. Welcome to everybody. Appreciate having us on. It's a shame can't do it in the flesh. I missed the TNG events, even though I'm blatantly over 30. I think by the time lockdown's done, I won't get away with that, will I, Dan? But I appreciate that. Appreciate that. So yeah, good to speak to everyone. I think there's three key points that I want to make. Good to work on things in threes like Ada did. And I think this is a subject that is really important to me and means a lot to me. I worked in drug treatment for 9 years. And I first got into that because I kind of saw the harm that drugs did, wanted to do something about it, and found that just like a ridiculously rewarding, incredible experience. But when I first started 9 years ago, I reckon on average, we would lose a client to a drug-related death or a health complication due to their drug use once every 3-6 months. And that was kind of like the average death rate when I was working in treatment. Like 9 years on from that, this was probably about like 4 years ago, I remember being at my desk really vividly, and then a friend and colleague of mine, I'd come back from a week on holiday and I was just sat at my desk looking at some case notes, and I said, oh, I saw client notes, I couldn't find client notes. I was like, oh, where's Jamie? And someone went, oh, Jamie died last week. Yeah, did you not know? And I was like, well, I'd known this guy for like 5 years. Like he's a client of mine, I'd known him for 5 years. And I was just like, what? We're just like casually, that's how we let people know now when someone's died. Like it's just this casual conversation. And I wasn't annoyed at my colleague and my friend. It was more like the culture. Drug-related deaths had just become so normal. This had been a thing where originally we were like, oh man, we lost a client. Like that's really rough. It had gone from that to like every 2 weeks, another client death, every week, a client death. And where I worked in sort of like the northeast, it wasn't even that bad compared to places like Leeds. Leeds, we were having like 30 client deaths a month. Like it's crazy. It's almost like a client a day. It's an unbelievable amount. And that kind of inspired me to be like, okay, drug treatment's great and rewarding, but there must be more I can do on this. And that's kind of what led me to working to kind of move into the policy space. So it's really important, and there's a lot we can do. And I think Steve will talk about some of those wider regulatory things that we can do, which are really important. But what I want to focus on is like 3 key areas that I think collectively, groups like VoltFast, groups like Transform, groups like ASI, if we keep campaigning, talking about this and push it for it, I think they're easy. I think they're fairly easy wins. The first one has loads of evidence behind it. This is something that the ACMD, the Advisory Council for the Misuse of Drugs, recommended to the government several years ago. And that is that we provide substitute heroin for people that consume that drug on a regular basis. So from working in treatment for 9 years, I can tell you with confidence that heroin is not really a drug that's trending amongst young people. I managed young people services for 4 years. And I think in all that time I saw there were two clients who used heroin, and both of those cases, they were exploited young people who were literally given heroin by older adults under like duress. It's not a drug that young people particularly want to use. So when we look at the drug-related deaths and when we look at the numbers, a majority of those deaths are from people that are using drugs like heroin. And there's a really very simple way in which we can help manage this cohort. And alongside that, there are some wider benefits, like criminal gangs would make less money because you could provide many heroin users with prescribed diamorphine. And there's great evidence behind it. It's something that the ACMD recommended, that you find those most vulnerable groups, find those people who are using drugs like heroin on a regular basis, and prescribe to them a substitute for that. There's great research behind it. There's great evidence. And there's some really good pilots that are now kicking off in the UK. In Middlesbrough recently, they started this. They've been doing some substitute prescribing there. Now, it's a little bit more nuanced and complicated than I'm making out. Methadone is included in that. Like methadone is a drug that has been used in drug treatment for years and years and years and years. You prescribe someone methadone, and the theory behind methadone is that will help them come off and stop using heroin. But sometimes with methadone, what I've seen in treatment is we need a little bit more than that. The problem with heroin users, problematic heroin users, is heroin is the best painkiller we have. If you broke your leg, not that I hope anybody does, but if you're in severe pain, you'll be given heroin as a treatment for that. You know, you're in excessive amounts of pain, given heroin, pain goes away. From working in treatment, the people that are at most risk of drug-related deaths are people that are using drugs frequently, drugs like heroin. And the reason they're doing that is they're in a lot of pain. And what heroin does is it removes that pain, physically and emotionally. So when it comes to substitute prescribing, what we really need is to match that. We could do with giving people diamorphine. We could do with giving people an equivalent to heroin rather than just a drug like methadone, which simply deals with the physical withdrawal. So there's great evidence behind it. The ACMD are recommending it. There's pilot studies going on at the moment, and that would go a long way to reduce the number of drug-related deaths. And just to give some context for that, I think the new stats come out in the next few days, or on next week. But in 2018, there were 5,546 drug-related deaths, which is 16% more than the year before. So opioid substitution therapy will be a great step in that direction. An easy win, protect the most vulnerable group, make some serious headway into reducing those statistics. The second thing that we could do, which there's growing momentum behind, there are positive things happening with this in the UK and globally, is we should implement drug consumption rooms. So the people have lots of different terms for DCRs. I'm using DCRs, and it's essentially a place where people can go and use a substance like heroin under the supervision of a medical professional. The reason that DCRs are so good, there's a global evidence base for them. You see them popping up around the world. North America, Canada's doing particularly well in this. No one has ever died in a DCR. And there's one really important piece of harm reduction information that I find myself saying all the time that many, many people don't know. Even people that work in drug treatment don't know this. And it underpins why DCRs are so important. The problem with drugs like heroin or any intoxicated experience is that the more comfortable and relaxed you are, the more able your body is, the better your body can deal with that substance. So to put that in like layman's terms, if you're at a wedding and you're drinking alcohol and you're a bit nervous and you're a bit tipsy and there's a lot going on, your body will be less efficient at breaking down the alcohol than if you just kind of sat chilling at home and feeling very relaxed. So the tragedy around heroin-related deaths, and something I saw from working in treatment, is that many, many overdoses are completely unintentional, and they occur when people are using in back alleys, dealers' houses, random locations that they're not used to. Whereas if you, regardless of the strength of the drug, which obviously plays a factor, but regardless of the strength, if you put someone in an environment where they feel comfortable and safe, then their body is much more, is more able to deal with that drug and break it down. So not only do drug consumption rooms immediately change the environment where people feel more comfortable, and appreciate that the most vulnerable cohorts where many of these drug-related deaths are occurring are where people are using drugs out in the street. A lot of people that have no fixed abode, people that are homeless, people that stay in hostels where there is no comfortable place for them to use a substance. Whereas if you have a DCR, not only is the environment safer and their body able to break the drug down more efficiently, but you also have medics on hand. No one's died in a DCR. It's a really, really strong stat. People don't die in DCRs, yet we see thousands of deaths in this country, thousands and thousands of deaths. So DCRs, again, similar to the opiate substitute therapy, great evidence behind it, growing global momentum for the evidence of it. There's actually, I encourage everybody to check out something that's really interesting that's taking place in Glasgow. As a drug science, Professor Nutt's organisation, I've just done a podcast with the guy who's doing this. He's called Kevin, and he's just off his own back. He started a drug consumption room. It's in a van. He's driving around Scotland. He's got his own drug consumption room. And there's very interesting discussions with the police around this. He's not been arrested. The first day the police were there, they just watched the van, no one went in. But since then, the relationships have improved and there's a level of tolerance and acceptance of this guy going around doing it in the van. It's a really, really interesting initiative. And I hope that's something that will grow. Similarly, in Canada, you saw, the drug consumption rooms were essentially implemented by strong activism. And I think that might be that what Kevin's doing in Scotland could be something that helps, grows and pushes that. So DCRs would be a great step in the right direction. I think another thing that's really, really important that would be a quick win, and is something that has support from many, many groups, regardless of your take on legalization, regulation. I think this gets this strong support across the board, is better drugs education. Now, testing is important, DCRs are important, but when it comes to harm reduction, knowledge is key and knowledge is power. And I think this is a really timely, relevant chat. As Adam mentioned, we saw 4 deaths last week in Newcastle, 4 drug-related deaths. And the tragedy of every drug-related death is it's often a knowledge issue, it's an education issue. And you know, nearly all the cases, it's not people intentionally doing this to die. People are seeking a particular experience and something's going wrong through the nature of their intoxication or whatever else by accident. And that's tragic. So what we need to do is we need to better educate people. And those education interventions need to be targeted. It's not a case of just telling everybody the same thing. You need to have different tiers with that. And again, the evidence base is really, really strong. Provide really broad drugs education for everybody. Make sure it's discussed at primary school. Make sure it's discussed at secondary school. And right now, Adra and myself are doing loads of work to try and bring the universities up to speed, because this is not a good time for students. Students find this a particularly difficult time. 4 students died last week. This is a really, really relevant time for universities to start taking this seriously. And again, it's a quick win. It's a quick win. The government, we wrote a report about this called Making the Grade. I think it was last year, or it was either the back end of the year before. And the government have kind of engaged a little bit more on this. They've refreshed the guidelines, but they've not gone anywhere near far enough. Now I think all that a school needs to do is provide 1 hour of drugs education in the entire sort of span of someone being at secondary school. That's it. Legally, they just need to do 1 hour, which obviously isn't enough. This needs to be a conversation we're regularly having with students, even if the conversation is as simple as, if you've got any questions about drugs, this is where you go. This is who you speak to. Just creating good links with treatment services, good links with welfare teams that exist within the schools. That's all it needs to be. So drugs education, massive passion of mine, something we need to do more on. I always think it's useful when I talk about things like this to groups, is to give like actions people can engage with and things you can do. Because I think there's sometimes we can have all these like really interesting discussions and people can get passionate about it. But it's really important, I think, to give actions that people that care about this subject to go away and do. The first is that it's really important at times like this that we promote safe, sensible harm reduction websites. So an organisation that Adra and I are involved in is Drugs and Me, www.drugsand.me. Adra and I will be able to put it in the chat at some point. It's a really clear, it's an evidence-based harm reduction website. It has the mentality of, if you choose to use a substance, this is what you need to know. We're not encouraging people to do it. We're not telling people to do it. We're not glorifying it. We're just saying, if you choose to use a drug, that's how you keep yourself safe. So sharing websites like that, creating conversations like that is really important. The second thing is, it's very easy when you talk about drugs and you talk about drug reform and you get passionate about subjects like this, it's very easy to kind of criticize and point fingers and give blame. From what I've learned in 9 years of drug treatment, if you want to change people's mind, you want to bring people on a journey, you've got to be positive. And I think now is the time to positively engage in education institutions, particularly universities like Newcastle. And we need to work with the media to not give the university a hard time, but instead to say, let's support you, let's work positively with you. And the third thing, I just think this is good, not only just in drug reform, but many of the subjects that you guys talk about at the ASI, is we need to go, people that care about this, if you're listening and thinking, yeah, I'm really passionate about this subject, it's something I care about, you must go find people who disagree with you. Go have conversations with people who don't think like you. Don't just follow the same people on Twitter who all agree with you. Don't just create little bubbles around harm reduction. The risk we have around many of these subjects that we're passionate about is we just do the same things with the same people who all agree with us. What we should be doing is going out and finding the people that disagree with us and positively engaging with them. Take them on a journey, give them a narrative, give them something to engage with. Don't just stick in the little bubbles. And that, yeah, I think that's it from me, Dan.
Thanks a lot, Paul. Just one quick point. I think the guy that's running the mobile DCR in Glasgow is Peter Crikant rather than Kevin. We might be thinking of different
that's
people.
Why, that'll be why Ant just gave me a note while I was talking. Said Peter.
Yeah, so that's Peter Crikant who's running.
Kevin all day. Sorry, Peter.
No
yeah.
worries.
And I'll put in the chat the link to the podcast, to the Drug Science podcast.
Yeah, please do. A couple of questions before we move on to our final speaker. One's coming in chat from Natalie Finch, who says, Paul, I feel pretty sure that the recovery agenda has contributed to this normalization of deaths of service users. Harm reduction has been pushed so far off the agenda, it's almost become an expectation that if people aren't working towards abstinence, they have to accept death as a possible outcome. Would you agree with that?
Yeah, so I contemplated talking about this, but I was slightly aware of time. So the time that I worked in treatment, when I first got there, it was very much about harm reduction philosophy. It was like, let's get the clients, if they choose to use heroin, that's okay. Like, I mean, we'll try and convince them to stop using heroin, but if they wanted to use heroin for the rest of life, that's fine. It was very much focused on let's keep people well, let's keep people safe. I worked through that transition into the recovery agenda. And I think there are multiple factors which have led to the increase in drug-related deaths. You know, it's not as simple as it just being one thing. But I think that the shift that I experienced in treatment has absolutely played a part. Absolutely played a part. You know, one of the major factors is the heroin. I mean, the ACMD report on this is really good. It highlights all these things, but it doesn't go in as hard on the recovery agenda as I would have having worked in treatment. But there was certainly a very significant shift from, instead of just keeping these people on maintenance prescriptions and letting them come in and saying, yeah, carry on coming for methadone, we must try and encourage people to go out and leave. And from someone that worked in it for years, it was incredibly uncomfortable because the entire dynamic shifted. And what we absolutely did, and it's sad, is that we deterred a lot of people from coming into treatment. And essentially what the message had changed. People were, when we were given methadone, they were like, you can be on this for the rest of your life. We just want to keep you safe. It suddenly changed from, you know, I've had incredibly difficult conversations with clients where it would basically be, well, we need to start coming down on your methadone, because, you know, you're not making any changes. And personally, that was another factor in me leaving treatment and moving into the policy space, because I felt a discomfort with that. And unfortunately, I don't blame the drug treatment services, because they were just simply following direction. Without going too much into this, one of the major problems is that the whole drug treatment sector is dependent upon winning local contracts from council providers based on tenders. So if you play the kind of like the moralistic game in drug treatment and say, no, we're going all harm reduction, well, you just won't get any contracts, because you won't meet the nature of the tender. And one of the biggest criticisms I have of treatment is that the thing that treatment providers are always aiming for are drug-free discharges. That's like the golden egg. And if you're chasing that, you're going to naturally be pushing people out. And I think there's been a slight reevaluation of that and a slight move back towards harm reduction, but I think we should go a lot further. And I think we should have systems in place that say, do you know what? If our main objective of the treatment service is to keep you well and keep you alive, show you empathy, show you connection. And when you're ready, you may stop using. But yeah, I agree with those comments. That certainly played a part.
Well, thanks, Paul. We'll leave it there for now, but there's a few other questions that have come in for you for the general Q&A. And we can now move on to our final speaker, which is Steve Rolls, who is the Senior Policy Analyst at Transform Drug Policy Foundation. And that's an organization trying to reduce the risks associated with drugs, promoting evidence-based policy around the use of drugs and trying to improve the lives of those who have been harmed by ineffective drug laws. And Steve has been pretty instrumental in Transform's development since he joined in 1998. He's published widely on drug policy and was the lead author for many of Transform's publications. He's also a regular contributor to the public debate on drug policy, both in media and in print, and has advised governments across the world in terms of drug policy reform. So he's going to be exploring some of the broader changes that may be needed for our legal and regulatory framework around drugs. And I'll hand over to him to talk more about that.
Thanks, Daniel. Thanks to Ada and Paul who've come before me. They've actually said quite a few of the things that I was going to say, so that's going to save me some time. I think the first thing to say is just how bad the problem is in the UK. I mean, it has been, we have seen a very dramatic, sharp uptick in drug deaths over the last 5-6 years in particular. Paul alluded to it. I think in England and Wales there was nearly 3,000 deaths in 2018. And that's a rise from around 800 in 1993. So more than a 300% rise in drug deaths. And a year on year, it's the highest level of drug deaths we've seen ever since records began. And in the UK has about more than a third of all the drug deaths in the EU, which is, it's a pretty shocking, pretty shocking statistics. So, and if you look at just Scotland, it's even worse. I mean, Scotland has the highest level, a higher rate of drug deaths than even the US. In fact, it's the highest rate of drug deaths of any country in the global north, where there's decent statistics. So, a really, really shocking record, and it's getting worse. The new drug death stats are out tomorrow, I think, or later this week. And they promise to be a disaster again. So clearly there's a major crisis here, and the government has totally failed to get to grips with it. So I think it's really valuable that you're tackling this. Paul's actually touched on a number of the things I was going to touch on, but I think there's one thing that I don't know if you mentioned, Paul, but it's actually the issue of funding for drug services, because at the same time as we've seen this alarming sort of spike in drug deaths over the last 5 or 6 years, we've also seen drug service budgets kind of collapsing. So public health budgets from central government have been cut dramatically, and overall across the UK in the last 3 or 4 years, there's been more than a 25% cut in budgets for drug services. So as deaths have been rising, funding for drug services that might actually impact on that have been going down, which is, you know, clearly unsustainable. And I think an essential part of the response, I mean, we can get into a debate about what services we need most urgently to address this problem, but an essential part of any response has got to be to reverse those budget cuts. And you know, quite aside from the terrible human cost in terms of drug deaths, you know, cutting drug services actually just, you know, from a purely cold, cynical economic point of view, it's a false economy, because all you do is you create costs downstream. You know, if you're not providing services, people are going to get hepatitis, they may contract HIV, they will get ill, and they create an economic burden downstream. So it's, you know, if the government thinks they're saving money by cutting drug services, they really need to reevaluate. Spending on drug services is proven to be cost effective in the medium to long term. So that is something that has to be addressed urgently as a fundamental structural shift. Paul's touched on this issue in the answer to that question after his talk, that really we need to put harm reduction back at the heart of drug policy in this country. There has been, since 2010 and the coalition / Tory government, there has been a kind of ideological shift away from harm reduction and a sort of ideological hostility to even the concept of harm reduction. The words harm reduction don't feature in the drug strategy anymore at all. They're not mentioned. You know, and alongside that, you have had this kind of, I fear, ideologically driven, not really evidence-based, over-prioritization of the sort of abstinence-based treatment and recovery agenda. Now, there's obviously nothing wrong with abstinence-based treatment. It's an important part of the sort of drug services toolkit, but you can't have a system that prioritizes it over other things at the expense of other proven harm reduction interventions, and Paul's touched on this. There are issues like payment by results that prioritize the wrong outcomes in terms of getting people, you know, out of the system drug free, that have had negative. It's not the only factor, but it's certainly been a factor. People have been pushed away from treatment, or been pushed out of treatment too early, or been pushed onto the wrong forms of treatment, or pushed off their prescriptions in ways that have had negative outcomes and may have contributed to the general climate that has fed into this alarming rise in drug deaths. The third point I wanted to make was really about the need to create space for innovations and the need to sort of get away from some of these ideological preoccupations of you know, that were driven by you know, a lot of it was Ian Duncan Smith and the Centre for Social Justice. There was a very much, it had a sort of bit of a religious tinge to it, some of it, that there was this ideological agenda around abstinence that sort of pushed away a whole series of you know, really quite promising arenas of policy development. And you know, the government stopped listening to their own experts. There was a brilliant report on reducing drug-related deaths produced by the ACMD. It was some years ago now. It's 3, 4, 5 years ago now, and very few of its recommendations have been taken on board. But a couple of things. Paul's talked about heroin prescribing, but I think probably the most fundamental one is the need to stop criminalising people who use drugs. So decriminalisation, ending the criminalisation of people who use drugs, is an absolute prerequisite for any meaningful public health interventions. You can't have a system that blanket criminalises the very groups and populations of often vulnerable, marginalised people who you are trying to support. It's a fundamental contradiction that sits at the heart of UK drug policy. And I think it's important to remember that, you know, decriminalisation now it's supported by the entire UN infrastructure, including the World Health Organization, including the UN Office on Drugs and Crime, It's endorsed by the Lancet, the BMJ, the British Medical Association, the ACMD. As I've already mentioned, the ACMD have called for an end to criminal sanctions of possession and personal use offences. The Royal College of Public Health, Faculty of Public Health, the Royal College of Physicians. There's this long list of, this isn't Transform and Volte-Face and, even the ASI calling for it. These are, august, quite conservative often, expert bodies saying it's not ethical and it's not effective to be criminalizing people who use drugs. And it creates obstacles to accessing treatment. It pushes people away from treatment. And, it drains resources. Criminalization drains resources into counterproductive punitive enforcement that really should be better spent on proven public interventions, things like treatment, things like harm reduction, things like risk education and prevention, things that we know can work, whilst we know that criminalization doesn't work. And again, it's an absolute precondition for any meaningful public health interventions. We don't criminalize people for their unhealthy diet or for unsafe sex or for any number of risk behaviors, but drugs or even drinking and smoking. We have public health interventions to try and minimize those risks and maximize health and well-being. We don't criminalize them, but we do with drugs, and the outcomes of that are there for all to see. I think it's particularly weird, the decriminalisation thing, because the government seems to be embracing this concept of diversion, which is 5 or 6 police authorities around the country have diversion schemes where people caught in possession of drugs aren't prosecuted, aren't even arrested. They're diverted into a health intervention. And for all intents and purposes, it is decriminalisation, but it's not called that. It's sort of de facto decriminalisation. The government embraces it, but if you ask about decriminalisation, they go, "Oh no, we couldn't possibly support that." Even though, again, with the Psychoactive Substances Act, people who are caught in possession of drugs covered by the Psychoactive Substances Act are not criminalised. It's not a criminal offence to be caught in possession of those. But if it's a drug covered by the Misuse of Drugs Act, it is criminalised. So it makes no difference. The drugs are of comparable harms. There's no difference at all. It's a fundamental inconsistency at the heart of our law. So decriminalisation, absolutely precondition for beginning to address these problems. And a number of the other things that flow from that, things like drug consumption rooms that Paul's talked about, so I won't revisit that. Things like drug safety testing. People, while drugs are illegal, people should be able to know what they're taking so they can make informed choices. Organisations like the Loop have provided this sort of testing, both in city centres and at kind of music events and festivals. And the government's kind of almost embraced it, almost approved it. They've done one Home Office approved trial, but it was very small in Weston-super-Mare. Really, that kind of service needs to be available not just at festivals, but in every city and town in the country. And in drug consumption rooms. I visited a drug consumption room in Copenhagen where you could get your drugs tested before you injected or smoked them. Why haven't we got those services in the UK? It makes no sense. I was actually reading a report we wrote in 2004, in which I expressed Transform's bewilderment that drug consumption rooms were still unavailable in 2004, despite all the international evidence to show that they were effective at reducing drug deaths as our drug deaths started to tick up. That was 16 years ago. 16 years ago, and only now we've got. We're forced into a situation where people like Peter Krychek in Glasgow are having to do kind of guerrilla supervised injecting vans. It's a ridiculous state of affairs. I think that's going to change. I hope that when the Carol Black report comes out, she's going to recommend drug consumption rooms and the government will have their hand forced and start a pilot. But really, who knows? Heroin assisted treatment, Paul talked about that in some detail. I mean, I think heroin assisted treatment really good. I mean, it's actually, as Paul said, it's legal in the UK. You can do it already. It's been legal in the UK since the 1920s. I mean, we kind of invented it. But again, it's proven, it's cost effective, it reduces drug deaths and a whole series of other outstanding health outcomes. The government should be funding it. It is quite an expensive intervention. It's one of the reasons we've only got 2, I think, pilot programs in the UK at the moment instead of 50 or 100. Really, it needs to be a nationwide program of provision for what is an essential service. I think it's worth saying that ultimately we do need to deal with some of the underlying drivers of problematic use. These aren't that we can't just deal with the symptoms of drug deaths. Yes, we can reduce drug deaths and stop people dying, but we also do need to deal with, you know, the poverty, the alienation, inequality, histories of trauma and abuse, unresolved mental health issues, and a lot of the kind of underlying drivers of problematic use in the first place. So I would contextualize everything I'm saying in that context. And finally, just to come on to regulation, which is the focus of a lot of Transform's work, it's not just criminalization that increases risks. It is the fact that a lot of the drugs people are using are supplied from an unregulated illegal market. That increases risks. And we do need to start having a debate around regulated markets and provision of drugs for adults that goes beyond cannabis. I mean, cannabis is, you know, obviously that cannabis legalization regulation debate has got its own momentum now, but it's not really an issue in the drug deaths debate because people aren't dying from using cannabis, but they are dying from using, you know, stimulants and opioids and benzodiazepines in growing numbers. And we really do need to start looking at how we can, in Canada, they call it safe supply. And we've, you know, in this conversation has already touched on it. Heroin assisted treatment is a form of regulated supply of a formerly illegal drug. Now, because it comes within a medical context, it's not seen as legalization regulation because it was legal anyway. And like I say, it's been going on since the 20s. But for the person who's moving from a street supply of heroin into a prescribed supply of heroin, their use has effectively been legalized. Their supply has been legalized. So we can already see for one of the most sort of, you know, threatening and most feared drugs, we already do have a legally regulated model for making that available. Now, are there other drugs we could bring within that kind of model? Yes, certainly. I mean, the stimulant prescribing is very under-researched, but there's enormous potential there. Benzodiazepine prescribing is something that happens on a small scale, but there are certain concerns about it. But not everyone is a problematic user. As Ada mentioned, a lot of people use drugs occasionally, moderately, and don't really have any significant personal or community health issues or welfare issues associated with the drug use. Those people should be able to access legal regulated drugs as well. You know, if you buy drugs illegally, they're of unknown strength and purity, they're often adulterated, they can be missold. And of course, there's no information on dosage, there's no health warnings, and you don't get to talk to the vendor about, you know, safety and harm reduction, all of those things that could happen within a regulated market. Now, obviously, there's a whole series of important questions about how a regulated market for something like cocaine or MDMA or LSD or other drugs might work. You know, how do we prevent commercial pressures and profit seeking leading to the sort of increase in use we've seen historically with alcohol and tobacco? You know, what products will we make available? Who would sell them? How available would they be? You know, where would you buy them from? How much would they cost? Who would have access to that market? Who would be allowed to, where would you be allowed to use them? Would you be allowed to advertise and so on? Now, those are all the sorts of questions that Transform's explored in our various publications. We've got a new publication out next week that's focusing specifically on stimulants, where we try to engage with some of these questions. We don't think we've got all the answers, but absolutely that is a debate that needs to be had. And I think that the terrifying rise in drug deaths, not just in the UK, but in much of the world, means that there is an increasing urgency for us to have that debate around regulation, because it couldn't be more clear that the whole war on drugs, the whole sort of paradigm has failed. You know, it's there supposed to eradicate drug markets and protect the health and well-being of people. It's done the opposite. Drug markets continue to expand, and health and well-being of both people who use drugs and the wider community is suffering. So we need to be having that debate. In the short term, decriminalisation, funding, innovation in harm reduction and service provision. But in the medium to long term, we've got to start having a debate around prohibition more generally and start to explore some of the options for regulation. And if people are interested in that, do come and check out some of the Transform stuff. I'll stick a link up in the chat. But I'll end there, Daniel, because I'm sure I don't want to take up any more time. And
No,
hopefully
thanks.
there'll be some interesting.
Thanks a lot, Steve. Yeah, there's plenty of interesting questions that have come in. We've got just about 10 minutes or so to cover them, and I'll make this a general Q&A, so all of our previous speakers as well. There's some that have already been answered by you there. Does the panel feel that tackling the drug death crisis involves legalizing and regulating all drug use, or would a harm reduction based approach ideally be linked in with decriminalization, legalization? Paul and Ada, maybe your opinions on those questions as well.
On the bottom two of the list, would a harm reduction approach based ideally be linked in with decriminalisation and legalisation of these substances? I think harm reduction is just something we should do regardless. And I think sometimes people see harm reduction as something separate to everything else. Ada and I were having a conversation with the university the other day, and they were like, "Oh, we don't know if we're up for a harm reduction approach. We kind of want to keep people safe." It's like, it's the same thing. Harm reduction is just the start of a good conversation in my eyes, and that's something we should do straight away. I think any major regulatory change to our legal framework around drugs is a great time to also have more of a conversation about things like harm reduction. But I just think that's something we should do straight away, and I think that's something that we should all work hard on to kind of reframe as a discussion. Harm reduction is not telling people to use drugs, it's not encouraging drug use, it's not turning a blind eye to drug use. It's just basically saying, if you were using substances, we value your life, we want to keep you alive and well, this is what you need to know. And what I found really interesting about treatment is having good harm reduction conversations with people is basically how you get them into treatment in the first place. It's like, basically it's saying, I care about you, let's have a conversation. And that is such a fundamental thing. That is how you then move some of the most stuck and difficult people in treatment out of treatment. So I think, I mean, yeah, sure, if you're doing wider regulatory change, it's a good opportunity to talk about it, but I just think that's something we should do straight away. And we should, everybody that's passionate about this, we should work really hard to kind of reframe what it is and move away from how some tabloids might talk about harm reduction into, you know, what it really is, which is just a positive, caring conversation.
Yeah, I'd just like to agree with you on that. I think it's really important not to separate the harm reduction debate from the debate around policy and law reform. I mean, the legal policy environment is part of what some academics have described as the risk environment. You know, policy, you know, all of the things we're talking about are filtered through the policy and legal environment. And a lot of the definitions, the Harm Reduction International definition of harm reduction includes a statement which is around, you know, addressing policies and laws which increase or exacerbate harm. So I see issues around, I see things like regulation and decriminalisation as enablers of a public health and harm reduction approach. I don't see them as, yeah, like you say, I don't think it's useful. And I also don't see treatment as separate from harm reduction. They're all part of the same thing, which is a focus on health and a focus on reducing risk and a focus on increasing well-being overall. And you can't separate the service provision from the policy and legal environmental questions in which it all plays out in.
Ada?
Yeah, I mean, I agree with both of you. As I say when I was talking first, you know, drug use is a spectrum. So, you know, if on this side we have people who are not using drugs yet, and on this side people who like are addicted and having problems, then you have policies for these people to, you know, to prevent them starting using drugs. And then here you have policies to treat these people. But then if you don't have anything here, it just doesn't make sense. And having harm reduction isn't mutually exclusive with, you know, making everything illegal or just having a preventative agenda. It just fits with any agenda. That's how I see it.
And I'd also say harm reduction is not hostile to abstinence. You know, abstinence-based treatment fits very much within a kind of hierarchy of goals in harm reduction thinking. But those have to be clinical decisions between service provider and the client. They shouldn't be determined by politicians from on high. The politicians should not be making clinical decisions about how an individual service user progresses through treatment. So, you know, again, harm reduction. Yes, it may be seen as a set of interventions, but it's also a sort of conceptual framework for looking at policy more broadly. and that includes law reform and decriminalisation, regulation, all the rest of it.
Yeah, I think that the kind of point you made there about abstinence-based treatments having a part to play, you can kind of see in some cases there's a synergy between harm reduction and abstinence. If you look at drug consumption rooms, for example, they're able through a harm reduction approach to reach populations for recovery services that otherwise simply wouldn't be reached at all and would have even less chance of successfully cutting the problematic drug use. A question that's come up from our director, Eamon Butler, and this is something I was interested in as well, the kind of, if drugs were decriminalized or legalized, how would you meet the argument that people will take more drugs and total harm will increase according to harm reduction's definition? And I guess more broadly speaking, what are the sort of the practical rather than moralistic arguments against adopting a harm reduction approach?
Is that one for me?
Yeah, go ahead.
I mean, I think, you know, the evidence for that punitive user level enforcement is an effective deterrent is very weak. You know, we can look at comparative studies between countries and comparative temporal studies that track how patterns of use change in light of, you know, policies getting harsher or liberalising, and you don't seem to see any clear pattern. There are countries with harsh policies and high and low levels of use, and countries with liberal policies with high and low levels of use as well. And it really seems that the key drivers of drug using behaviours are much more to do with wider cultural, social and economic trends than policy. There's a sort of arrogance of politicians that they think their policy pronouncements will somehow have some big impact on levels of use, and I don't think they really do. I think there is a risk if we legalised and had an aggressively commercialised market. We could see, like we did with, you know, tobacco in the 1950s or alcohol at various points in time, including now considerably. You can have aggressive marketing and promotion. You can have people profiting from unhealthy patterns of use, and that's something that any policy design would need to carefully mitigate against. And this kind of things that Transform proposes, that you would have unbranded products and, you know, state monopoly retailing models, and complete bans on advertising and marketing, of the kind of restrictions we've seen actually with tobacco in recent years. And tobacco use has been tracking down for about 3 decades now, as without resorting to prohibition, but as regulation has become more appropriate to the risks of that particular drug, at the same time as use of cocaine and cannabis and MDMA and multiple other drugs has actually been tracking upwards, because they're completely unregulated. So we need to draw on lessons from regulating risky products and behaviours, and decide what we think is appropriate. They're not easy questions. We would need to see what was working or what wasn't, but I don't think it's impossible, and I certainly don't think it's a given that decriminalisation or legalisation will intrinsically lead to an increase in use. And I certainly don't think it will lead to an increase in harm, because the nature of the use itself would be fundamentally safer, because the products would be safer. You could encourage safer using behaviours in safer environments. So even if use did increase marginally, you could still get a dramatic drop in overall harms, and the subject of this webinar, a drop in mortality.
Just to jump in quick, I guess that's the way when I've debated this a lot, people say this to me all the time, and I think that's kind of the thought exercise that's worth having when people consider this. It's, which are you more bothered by? Really acute harm of a small number of people, which equals lots of deaths, or lower level harm where you don't get many deaths, but it's across a broader range of people? I think that there's a difficult conversation around like legalization of drugs, and I think it would be unfair to say drug use is absolutely not going to change. It may well go up. If you legalize weed, you probably will get more people smoking it, because it's quite a fun drug and it's not particularly dangerous. So you probably get more people doing it. But the harm that they would experience, as Stevie's highlighting, would be so much lower that, to me, that would be, I would prefer much lower harm amongst a wider range of people than really acute harm, because one of the biggest damages I saw in treatment, one of the most dangerous things about drugs like cannabis, is a criminal record that affects you for the rest of your life. It's not a bad experience from cannabis. That stays with you forever. Whereas in a model where it's legalized with better systems of education, yeah, sure, people are still going to use drugs problematically. You know, in Canada, weed's legal, but are people still addicted to it? Yeah, sure they are. They're definitely addicted to it, and people are still using it problematically. But is it safer to do it now in Canada than it was 5 years ago? Absolutely, absolutely. And I think that's kind of the thought exercise to have. Do you want small acute harm, or are you more comfortable with wide lower level harm.
Ada?
And I think a lot of the decisions people make about their health are personal decisions. So, you know, yes, maybe government bans something, but it doesn't mean that they're going to follow that. You know, we've also seen in the COVID situation that government does something, but people either follow it or not. So in these cases, it's very important that the government has credibility and legitimacy in these issues. And there is increasingly more evidence about the relative harms of these substances. So when people see these evidence, you know, they feel deceived. The government puts himself in a hypocritical position and they lose their legitimacy and credibility. And, you know, then why would people believe them for anything they say? So yeah, that's what I want to say.
So there are a couple of questions unanswered, but unfortunately we're out of time at the moment. I'll just quickly mention an anonymous attendee makes the point that whilst there's national headlines around drug deaths, there's also last month in the UK we lost 18 people to paracetamol related deaths. Perhaps the mainstream media and policymakers profit from disproportionate fear of narcotic use. I think it's worth highlighting that. And another question from Harry Sumnall, which I can't see in the chat anymore, but was trying to tackle the point that a lot of drug-related mortality or disease is not just caused by currently illicit drugs, but related to issues like liver disease and alcohol, and also related to COPD, and that being related, of course, to smoking and how we could perhaps integrate our drug response as a whole. But sorry we didn't get to cover those questions in detail. Thank you all very much for joining me for what's been a really interesting webinar. And please do tune in for next Tuesday's webinar, which we'll be announcing shortly. But thank you, Steve, Paul and Ada very much for your insights. And thank you all at home for joining us. See you next time.
Thanks, everyone.
Cheers.
Thank you.